Let's begin with the normal lab value for potassium, which the NCLEX expects you to know is 3.5 to 5.0 milliequivalents per liter. Anything outside this range can cause serious, often cardiac-related problems, making this a critical topic for ensuring patient safety on the exam. First, let's tackle hypokalemia, where the potassium is less than 3.5. Think of hypokalemia as making everything in the body low and slow. The most common causes you'll see on the exam are related to potassium loss, primarily through potassium-wasting diuretics like furosemide or from the GI tract due to vomiting, diarrhea, or NG suction. An exam question might describe a patient on furosemide for heart failure who now complains of severe leg cramps and fatigue. This clinical picture should immediately make you suspect hypokalemia. The symptoms follow the low and slow pattern, including muscle weakness, fatigue, decreased bowel sounds leading to constipation or even a paralytic ileus, and most importantly, cardiac dysrhythmias. On an ECG strip, the classic signs are a flattened T wave and the presence of a U wave. This is a favorite visual identification question for the NCLEX. The number one safety priority and a guaranteed exam topic is how to administer potassium. You must never ever push potassium intravenously, as this is lethal and will cause cardiac arrest. It must always be diluted in an IV bag and infused slowly, typically no faster than 10 milliequivalents per hour, and the patient must be on a cardiac monitor. They will try to trick you with options like administer 20 milliequivalents IV push. Now let's shift to hyperkalemia, where the potassium is greater than 5.0. This is the opposite of hypokalemia, so think of the body as being tight and contracted. The most frequent cause on the exam is renal failure, as the failing kidneys are unable to excrete potassium. Other key causes include potassium-sparing diuretics like Spironolactone, ACE inhibitors, and crush injuries that release large amounts of intracellular potassium. A classic exam scenario involves a patient with chronic kidney disease who missed a dialysis appointment and now has a potassium level of 7.0. Symptoms include muscle twitching and cramping, which can progress to paralysis and profound, life-threatening cardiac consequences. The hallmark ECG change for hyperkalemia is a tall, peaked T wave. Seeing this on a monitor is a medical emergency. Exam questions will test your ability to prioritize. A patient with a potassium of 6.8 and peaked T waves is your highest priority over almost any other patient. Immediate nursing interventions are critical. First, you stabilize the heart's muscle cells with IV calcium gluconate. Then, you shift the potassium back into the cells temporarily using IV regular insulin with dextrose. The dextrose is crucial to prevent hypoglycemia from the insulin. Finally, you actually remove the potassium from the body using medications like sodium polystyrene sulfonate or Kayexalate, or for severe cases, emergent dialysis. Here's your mnemonic to link the ECGs. For hypo-K, think low, so you get a low, flat T wave and a U wave appearing below the baseline. For hyper-K, think high, so you get a high peaked T wave. A common exam trap is confusing the diuretics. They'll give you a patient with a high potassium level and ask which medication order you should question. The answer would be Spironolactone, the potassium-sparing one. Always connect the patient's condition, their medications, their lab values, and their cardiac rhythm. That is how you will correctly answer these complex priority questions on the NCLEX.